So today, Maria da Costa will present on transcranial photobiomodulation to manage symptoms related to depression, anxiety, and ADHD. Then we'll have a quick Q&A and a couple of announcements. So Maria, we are just thrilled to have her present today. She graduated from Nova Southeastern University with a bachelor's in biology and a minor in psychology, and she has research experience in epigenetics and cell therapy. She now works doing an incredible job promoting and coordinating Neuronic's research efforts. So Maria, feel free to say any other words or just dive right in.
No, that was great. And I'm just happy to be here to talk more about PBM. Today, I'll just give a quick overview of what is the research available on the effects of PBM for depression, anxiety, and ADHD, as well as giving just a quick overview of what these conditions entail. So to start with depression and anxiety, just a quick overview. So depression, which is also known as major depression or major depressive disorder, is a common but very serious mood disorder that causes symptoms that affects how the person feels things and handles daily activities, such as sleeping, eating, or working. To be formally diagnosed with depression, the person needs to have several symptoms on the DSM-5 that must be present for at least 2 weeks. And there are different types of depression, some of which develop due to specific circumstances, as I will briefly mention in the next slide. So in terms of its incidence, when people refer to depression, they're often talking about major depressive disorder. And according to the World Health Organization, about 280 million people worldwide have clinical depression, including 5% of the world's adults. And major depression in the United States is considered a major psychiatric disorder. In 2021 alone, an estimated 21 million adults had at least one major depressive episode, which represented 8.3% of all adults. And this prevalence is seen higher among adult women at 10.3%, and it's highest among adults between 18 and 25 years old, with an incidence of 18.6%. So it's clearly a major issue and worldwide in the United States. So depression can be caused by a combination of genetic, biological, environmental, and psychological factors. But when looking at it, the biological factors, there's two hypotheses that stand out and then can be related to PBM. So the first one is the serotonin and monoamine deficiency hypothesis. Serotonin, which is considered to play a vital role in the physiophysiology of anxiety and mood disorders like depression, and plays a vital role in the biological basis of depression. And the monoamine deficiency hypothesis suggests that depression results from an imbalance and deficiency of these monoamine transmitters, which are serotonin and noradrenaline in the central nervous system. And then there's another hypothesis on the effects of the brain-derived neurotrophic factors, or BDNFs, in depression. So BDNF plays a crucial role in neuroplasticity processes in the prefrontal cortex and the limbic system. Downregulation of BDNF due to factors like chronic stress reduces the neurogenic cell survival. And research has shown that reduced levels of BDNF directly contribute to this depressive symptoms by affecting the hippocampal function. Interestingly, research has shown that transcranial PBM directly influences and increases the levels of BDNF production in neurons. So these two biological pathways related with depression shine a light on the potential mechanisms of which PBM can help alleviate symptoms related with depression, as we'll see in the next slides, where I'll go more into the research. So before that, I just want to quickly mention that there's multiple types of depression, but I want to focus on seasonal depression, which is also called seasonal affective disorder, which involves changes in mood that happen alongside changes in the season. And for many people, this type of depression begins in autumn and lasts all throughout winter. So the exact cause of seasonal affective disorder is not fully understood, but it's often linked to reduced exposure to sunlight during the autumn and winter days. This is interesting because it just shows that there is a direct link into mental health and the onset of depression with exposure to light. And sunlight is the only type of light naturally that provides all wavelengths of light from the ultraviolet to the near infrared range. So that's how we can say that PPBM may have a direct influence in alleviating symptoms of depression. In terms of seasonal affective disorder, the main theory that causes this disorder is that the lack of sunlight stops it stops the hypothalamus to work properly, which affects the production of melatonin, as well as the production of serotonin and the body's internal or clock or the circadian rhythm. So now to talk about generalized anxiety disorder, which is one of the most common mental disorders, it's characterized by persistent, excessive, and unrealistic worries about everyday things. This worry could be multifocal due to like finance, family, health, and future. But this anxiety disorder is often accompanied by many physiological and physical symptoms, such as fatigue, tension, irritability, and problems with sleep and concentration. In the United States, general anxiety disorder affects a population of about 7 million people, which is 3.1% of the population, with a lifetime prevalence of 5. And there's an overlap on the symptoms experienced in anxiety and depression disorders, which are correlated with imbalances on the same neurotransmitters that I previously mentioned, like serotonin, norepinephrine, and dopamine. And people are often diagnosed with both conditions. So there's a high comorbidity rate. So now that I'm finishing this quick review of these two disorders, I'll go on the research on photobiomodulation for depression and anxiety. So this first study was conducted by Shaggy and colleagues, where they conducted a study designed to assess the anti-anxiety and antidepressive effects of near-infrared light in a chronic restrained stress, or CRS, mice model, using behavioral experiments, including like an open field and tail suspension and elevated plus maze test. These are just standardized tests used to measure like depression and chronic stress in a mice model. In addition, in the study, they also measured the levels of serotonin and nitric oxide in the prefrontal cortex and hippocampus areas to illustrate the possible anti-anxiety and antidepressive molecular mechanisms of PBM. In terms of the device specifics, for this study, they used a near-infrared diode laser with 810 nanometer wavelength at a pulse rate of 10 hertz, with an output power of 200 milliwatts and a power density of 475 watts per centimeter square. And in this study, they had 3 different active arms with the doses of 4, 8, and 16 joules per centimeter square, which were delivered to the cerebral cortex of the mice to see which dose was the most efficient at reducing symptoms of anxiety and depression. So the study included 55 male mice, which were then randomly assigned into the 5 different groups. There was a control group, a sham, and the 3 intervention groups with the 3 different PBM dosage. After the adaptation period, the CRS procedure was conducted for over 3 weeks as a typical stress model. And the laser treatment started simultaneously with the chronic restraint stress model and was given 3 times a day for over 3 weeks. And then they conducted the behavioral test from days 21 to 31 and did this sampling of serotonin and nitric oxide levels day 32. And mice in the control group were just handled gently daily with no PBM intervention. So now looking at the results, here we see the results from the elevated maze test. The figure on the left shows how much time the mice spent being active in the central zone of the maze, which is considered a healthy behavior. And we see that the sham group spent significantly less time in the central zone of the maze compared to the control group and the 3 intervention groups. And the 8 joules per centimeter square group showed to be the most effective in terms of the behavioral symptom of tested in this test. Then similarly, the immobility time of the mice were also measured. The less they move, the more signs of depression and anxiety they're expressing. And the group that received the dosage of 8 joules exhibited lower immobility compared to the sham and to the other groups, as you can see here. In the study, they also measured cortisol levels, and the results show that it's evident that the PBM intervention at all 3 dosages helped keeping cortisol levels low when put under stressful conditions, way lower compared to the sham group, as you can see here. And then in terms of the levels of serotonin measured in the prefrontal cortex and the hippocampus, in the left side is the prefrontal cortex and the right side is the hippocampus. We see that both groups receiving the 8 joules per centimeter square and 16 joules per centimeter square showed an increased production of serotonin compared to the sham group. And these results were statistically significant. So then they did a correlation to investigate if the depression-like behaviors from the maze test were directly related with brain serotonin levels. And the associations between the immobility time in the maze test and the serotonin levels in both the prefrontal cortex and the hippocampus were measured and showed that it was directly negatively correlated. So the correlation coefficients for the prefrontal cortex and the hippocampus were at 0.87 with p-value of 0. So the results obtained with nitric oxide were pretty interesting. The PBM doses of 4, 8, and 16 joules per centimeter square led to significant decreases in nitric oxygen levels in the prefrontal cortex. And in the hippocampus, we saw similar results with the 8 and 16 joules per centimeter square doses compared to the sham group. So this is an interesting finding because PBM is notably known to actually increase nitric oxygen levels in the cell. So to further understand this outcome, it's also important to look at the correlation between serotonin and nitric oxide in depression and depression mice models. They did a scatter plot to show the correlation between serotonin and nitric oxide, and it clearly shows that there was a negative correlation observed between the levels of nitric oxide and concentrations of serotonin in the prefrontal cortex and hippocampus. To understand this, looking at the literature, in depression mice models, it has been already shown that decreased levels of serotonin levels in the central nervous system were associated with increased nitric oxide levels. And that's why there's actually some nitric oxide synthesis inhibitor drugs that have been shown to be effective for depression treatment. How this happens is that enhanced nitric oxide production triggers soluble guanylate cyclase, or P, levels. And these extreme levels of cGMP are associated with depression-like state in animal models. In this study, it seems that the increase in serotonin from the TPBM intervention is coupled with decrease in nitric oxide levels. And I'm curious to also discuss these results at the end of the presentation, because I think these are interesting, and it just shows that further research is needed to understand the direct relationship between PBM, serotonin, and nitric oxide. So in general, the effects of for the study were shown to be dose dependent, and it showed that the maximum anti-anxiety and antidepressive benefits were induced at the 8 joules per centimeter square dosage. Well, there were still benefits seen at the 4 and 16 at a lower and a higher doses. Its most efficient was at 8. Now, moving on to the clinical trial with human subjects, Dr. Paulo Casano and colleagues organized a randomized, double-blind, sham-controlled pilot trial to study the antidepressants effects of transcranial PBM in patients with major depressive disorder. The study participants for the study were 21 adults aged from 18 to 65 diagnosed with MDD, and they needed to have at least moderate level of depression severity with a score between 14 and 24 of the Hamilton Depression Rating Scale. For this study, they utilized an 823 nanometer LED device with continuous wave stimulation, which was delivered twice a week for 8 weeks. And they used the Hamilton Depression Rating Scale as their primary endpoint, and they made as well observational analysis at baseline and throughout the intervention period with adverse effects reporting. So for the intervention, the eligible subjects were randomized for this 8-week study with stimulation twice a week, which totaled 16 sessions. And they were double blind randomized into the TPBM active group versus a sham treatment group. And researchers were targeting the dorsolateral prefrontal cortex, simultaneously directed the light to the F3 and F4 sides of the forehead, derived from the EEG placement maps. And throughout the study clinician had the option to adjust the duration of light exposure after completing sessions 6 and 10 respectively, from 20 minutes to 30 minutes. And each device had a treatment window of 28.7 joules per centimeter square. So the maximum cumulative dose over the entire treatment course was 43.7 kilojoules. This table summarizes the data collected in this study and the adverse events reported. The onset of several adverse events occurred within 24 hours from the first PBM session, which can be included or explained that the first session is usually when the patients are not used to this type of intervention. And the adverse effects, such as headaches, occurred within 1 hour of the PBM session. But all of these possibly related adverse events were either very mild and they subsided by themselves. So overall, the PBM treatment was fairly well tolerated, with none of the adverse effects causing study discontinuation or requiring dose adjustment. So in terms of the results, the mean change in the Hamilton Depression Scale total score was significantly greater than in the subjects receiving the sham mode, as you can see here. And the difference between the first figure and the second is that the first one is including all participants throughout the study, and the second figure is all participants that completed the study. So going to another study, this is the study, the effects of PBM on generalized anxiety disorder. This was conducted by Maiello and colleagues, and they looked for participants with a primary diagnosis of generalized anxiety disorder. And they were required to not have any antidepressant or benzodiazepine medication within 6 weeks of the screening visit. And eligible subjects were participating in an 8-week pilot open label treatment trial and each subject self-administered the PBM treatment for 20 minutes once daily at home for 8 weeks. And the specifics of the device were as follows. So they use an 830 nanometer LED device with continuous wave stimulation with an average irradiance of 30 milliwatts per centimeter square. And the total energy delivered per session was 2.9 kilojoules and a total output power of 2.4 watts. So the outcome measures utilized were the Hamilton Anxiety Scale, the Clinical Global Impression Severity Scale, and the Pittsburgh Sleep Quality Index subscale. And 15 participants were included in the study. So here in the results, we see that researchers reported the rates of responders according to the Hamilton Anxiety Scale scores were significantly reduced. And as well as the CGI scale, where they showed significant improvements at the endpoint session, at the endpoint observation. Out of the 15 recruited subjects, 12 completed the trial, and the results showed significant reductions in all the scales utilized. So here you can see the results shown for the Hamilton Depression Scale, and it showed significant decrease in comparison to from baseline to the endpoint. So finally, to talk about ADHD. ADHD is a neurodevelopmental disorder that is marked by an ongoing pattern of inattention and or hyperactivity, impulsivity that interferes with functioning and development. So males, especially children, tend to show more hyperactive symptoms, whereas females tend to show more of this inattentive symptoms. So this makes it so girls and women tend to be undiagnosed for many years until reaching adulthood. And while there's no known specific cause for ADHD, variations in neurotransmitter levels, such as in serotonin in the brain, can contribute to the severity of the symptoms. So as probably all of you know, because like dopamine helps a person to focus and rewards the brain for completing tasks, the presence of lower dopamine levels in the brain means that a person might have trouble maintaining focus on a task and seeing it through the end. And it has been suggested that people with ADHD have more dopamine transporter proteins that work to remove dopamine from the brain. So if there's too many dopamine transporter proteins in the brain, too much dopamine is being removed too quickly, and hence the symptoms occur. And it has also been proposed that ADHD is associated with changes in functional connectivity and resting state networks of the brain. Many of the symptoms associated with ADHD can be traced to deficiencies or altered networks in the prefrontal cortex, basal ganglia, and limbic system. So in terms of research for ADHD, there's very little research available at the time. I was only able to find 2 studies looking at this clinical population, and I'll briefly mention them. So the first study was a light therapy open label trial that used these 10,000 lux light boxes, which use for like a wavelength of around 484 nanometers. So this is not infrared light, but I decided to include this study in the presentation as it was very well conducted and rigorous. And the results shown that there might be a direct effect of sunlight or light therapy in some shape or form and symptoms of ADHD. So the study consisted of 29 adults between 18 and 60 years old with a diagnosis of ADHD and a history of the condition from childhood. And participants went through a very extensive screening process. The measurements for this study were self-report ADHD scales, including the Wender Utah rating scale, the Brown Adult ADD scale, and they also measured sleep-wake cycles, which they used the Horn-Osberg Morningness questionnaire. or MEQ. The results from this study showed that after a 3-week trial of morning light therapy administration, the researchers found significant improvements in mood, core ADHD symptoms, and objective measures of attention, as well as a circadian rhythm shift towards the mornings. These changes observed were statistically significant, and after a 9-week follow-up, the participants expressed continued improvements. And then lastly, there was the only other study that I was able to find that directly tested PBM for like near infrared light PBM with adults with ADHD was a case series study that used testimonials. So for this study, they utilized the Theralace laser head device, and that had 5 poles, 905 nanometer diodes with 200 nanosecond pulse, and each diode was capable of administering 200 milliwatts of average power. And then the device also has other 4 660 nanometer diodes. And the treatment procedure basically consisted of the patients were treated in 4 areas of the forehead over the prefrontal cortex for 2 minutes, for 2 minutes and 15 seconds per site. And the power settings basically showed that the energy delivered per sites was 79 joules, and the total energy delivered over the 4 sites was 315 joules. So from the testimonials, out of the 7 testimonial cases, 6 participants reported immediate improvements after a single session of PBM, and 5 participants decided to continue doing the PBM treatments as they found that there was significant improvements. So one of the testimonials shown in this case series study was from a 22-year-old guy that had a history of ADHD with poor organization and task management problems. He had previously used conventional and alternative treatments, which didn't really work for him. And after the first light therapy treatment, he noticed immediate improvements and actually stopped taking his Adderall medication right after and continued using the PBM treatment offered in this clinic. And then another case testimonial reported was from a person with an ADHD diagnosis that had reported issues of elevated levels of anxiety and excessive energy. And she often had issues with controlling emotions, as she was known as the queen of road rage, having issues controlling with anger management. And after intervention with the PBM, her rage episodes stopped, and she had more control over task management and time management. And her 8-year-old son also did the intervention, who had serious emotional self-control issues. And after the PBM session, his demeanor changed, and the continued arguments and fights ceased to occur, according to the testimonial. So, of course, the study is very preliminary and only relies on the doctors and the patients' testimonials. The positive effects evidence could be placebo effect. And another issue with the study is that it only relied on testimonials. They didn't complement it with any other measurement, and they only did the testimonials after a single session, and no follow-ups were made. So the study is pretty rudimentary. However, it shows a light that there might be a potential benefit of PBM for ADHD, and there needs to be further research with longer intervention periods and standardized measurements and more controlled studies for this. But in conclusion, PBM holds a promise to be a non-invasive, potentially effective treatment for depression, anxiety, and even perhaps ADHD. More research is needed, but by targeting specific areas of the brain with M may offer relief of symptoms associated with these conditions, and providing a safer, more accessible alternative or complement to traditional treatments. However, more research is needed, and this is still a very new field in the PBM research. So it's really exciting to see where we will go next based on these preliminary findings. So that has been my presentation.
Thank you, Maria. We really appreciate the time you invested in reviewing all that research and sharing your knowledge and findings. And it's just so exciting to see just the cortisol, serotonin, nitric oxide, and how PBM could be effective in depression and anxiety and potentially in ADHD. That pilot trial really indicates that more research is needed, but those results, or at least the testimonials, were impressive. Does anyone have any questions for Maria, or can you share any of your experiences using PBM in any of these similar disorders? John.
I'll jump in.
Yeah.
Thanks, Maria. That was terrific. I must admit, I don't know how many neurofeedback providers are on this call, but I must admit to some discomfort at the very beginning. Maybe this is my prejudice. Please correct me if I'm wrong. The feeling I had in the presenting of the first studies that you were talking about the decreases of serotonin, monoamines, BDNF, and all of that. It sort of felt like that was the horse driving the cart of depression. And I would argue only that the dysfunction of the hippocampus and the prefrontal cortex is probably the deeper reality. And so I would advocate towards neurofeedback as probably being the best intervention. The conclusion I was drawing from those they're not yours. I understand they're not your studies. Sort of reinforces that. Well, you don't have enough serotonin. That's your problem.
Yeah.
And it's
the reality is it's a more complex issue.
Exactly. And I understand that's the ground basis of what you're of this presentation is. We have an intervention that's going to help that, and I'm all in favor of that. I'm taking notes. I'm going, okay, that's not why she's presenting this. I know your conclusion was going in a different direction, but I have to say there's so many of these studies out there where that's going to be the takeaway. Oh, I need to get more serotonin, therefore I need to take an SSRI. It's obviously there's a logic to that. So Will's nodding, Patricia's nodding. So the people in the neurofeedback field obviously are violently opposed to that kind of conclusion. But I love this stuff, and I'm really interested in the ADD thing. So I know that's white light, and I know it's the wrong nanometers. But again, I think if I'm sitting here talking to a parent with an ADD child, I can easily say, the question I always ask, how much time are they spending outdoors? Are they getting light? That's the underlying reality of this, that you have a very focused intent, procedure to deliver light therapy. And adjunctively, just go outside for a while, get some nature, get some actual light, because there's obviously benefit to all the different nanometers. Everybody's nodding. I love this. So we certainly do that as part of our intake procedures. We ask about how much time do you spend in nature. That's our sort of catch-all, for how much do you get outside. But I think probably I need to start drilling down a little more specifically into how many hours of actual sunlight are you getting every day? Because we know culturally none of us are getting enough. Vitamin D levels are down. There's a lot of discussion around that, especially for women. I'm sorry to say, just socioeconomically, women are more trapped indoors than men are. It's unfortunately part of life. What else did I want to ask about? Are we going to get references to? I took notes on the studies. Are they going to be in a forum somewhere? Okay.
Yes, we'll share the slides, correct, Brooke? And they're all included in the slides. It's just they're pretty small, so it's hard to see in the presentation. But it's all linked to their research articles.
If you can give me some hot links, I'll put them in my folders and I can share these with clients. Yeah, because I had Asagi, Casano, and Maiello. Those are three very interesting research studies that I want to be able to reference for clients. There was a gentleman on the call who talked about people buying these helmets. I've been on. Okay, here's how I'm doing it in the clinic. Just to give you, we're experimenting. Clients come in, they're doing a neurofeedback session. I'm adding in 10 minutes of the helmet in a session. Now, I'm mindful that It's not enough. Truthfully, it's just not. I don't expect any huge changes that I can relate to the use of this helmet. So
Yeah.
my fear is clinically, I'm confusing the client. What's working? Is it the PBM? Is it the
Or
neurofeedback?
yeah.
You know what I'm saying? So, I mean, I got a business conversation I have to have with myself about that. But I'm very much in favor of additive modalities, and we use HAG. We use a lot of different things that are not necessarily straight neurofeedback. We have a functional medicine health coach who helps on nutrition. So I'm certainly willing to share the improvements that a client may make with the different modalities that we employ. But I can't figure out how 10 minutes, 20 minutes a week is going to be helpful to them. And I need to cross the bridge as to how to ask them to truthfully invest in this technology and take it home and use it. I'm thinking of a rental option. Maybe this is not the right forum to do this in, but I need to bring it up and see if anybody else has experience, because that one gentleman said he'd sold like 6 of them. I'm like, wow, I don't know enough clients who are going to shell out $3,500, $4,000 for a helmet to take it home. You know, they're already paying me a fortune to do this. Andrew's nodding. How do you add on that level of expense into what we know is going to help them? But, you know, you have to give them some demonstrable reason to do this other than my saying it. So if anybody has any thoughts on marketing and all the rest of it and how to actually do that, I'd be interested in that gentleman finding out how you could get people to shell out that kind of bucks for this. Thank you. Great job,
Thanks.
though, Maria. Thank you.
Thank you. No, and I quickly want to mention that what was interesting about the light therapy study on the ADD adults was that they did a really good job at measuring the effects of like the light therapy on the circadian rhythm, because people with ADHD are notably known to have issues with like sleep disturbances, having issues falling asleep or having issues waking up. And they usually have like their circadian rhythm is more towards like the late, like it's later in the day. So what they found in the study is that by using the light therapy early in the morning, they were able to shift it to the morning. And then that was coupled with a lot of improvements in focusing and in task management. So I think that was pretty interesting.
There was also a clinician in Chicago who was renting her devices out at, I believe, a month increments. So she would send them home for about a month. She also did home visits. That's another model she was using. She would literally go to the house. But we can take a poll and about the people with rental options and see which one is working best for them. And Patricia, you had your hand raised. I don't know if you were answering John's question or you had something else to say.
Well, I was going to add, some information that I have a colleague near me who has an 880 helmet, and she's been using that for about 10 minutes prior to her neurofeedback, but she does neurofeedback as well. And she reported to me that her clients are telling them that it increases their calmness, so that they are actually giving her feedback that's positive. I don't have, unfortunately, I had to close my neurofeedback practice down. So I've been attempting to talk to my clients about being preventive, getting the Neuronic for prevention as they're aging, because I think it's very good. I was really surprised, Maria, that they only used 8 weeks as part of their study, because I found that when I started using V-Light a long time ago, it took a while for AD to hook in and to really show a difference in terms of recall. And just recently, I stopped using my Neuronic for a little bit, and I started having problems with recall. So I was using. So obviously, there is some I think that there is certainly some reasonableness in terms of prevention for aging, for all kinds of, because I'm a lot older than most of you. And so it's just going to be a part of my life as far as I'm concerned. I mean, it is so reasonable in so many ways. So I still recommend it to even my counseling clients, but I haven't had any purchases yet.
Patricia, do you know what your colleague, what pulse rate, if any, they're using, or they're just using this
880.
80 nanometers, but is it pulsed at a particular frequency or just the glow function?
That I don't know. I didn't
Okay.
ask.
That's a discernment I'm trying to figure out, to be honest.
Okay.
And
You know.
John, for you utilize what, continuous wave for your clients?
I'm experimenting.
Experimenting?
I'm seeing how it goes. You know, I'm doing some. I start with glow because that's the
Mhm.
low hanging fruit. Let's just not do anything crazy. Let's just put it on glow and see how that goes. So we do 2 or 3 of those, and then I'll go, hey, let's try 10 hertz and see how that feels. You know, I got a lot of high beta clients in the, prefrontal high beta, so I'm a little reluctant perhaps to go to the 20 hertz, but I just don't know the answer to this clinically. If anybody's got contributions that can help me thread through this, I'd much appreciate it.
Will, did you want to add to something, or you have another question?
Yeah, more so another question. It kind of relates to John's kind of old question with, 10 minutes potentially not being enough. But I suppose, obviously, a question for you, Maria, and it's a loaded question, you could say. But if you were like a therapist yourself, or even in a neurofeedback clinic, of course, the biology is not the main focus when it comes to, I suppose, mental health, but it's certainly a factor. And we've seen PBM with the changes, with the biological changes. Do you think it would be good to incorporate the device kind of right at the start of a therapy session and then towards the end of the therapy session? So you have it on right at the start and right at the end in order to kind of distill or provide a certain amount of support during that session, kind of have that longer effect? Or do you think it just needs to be before or just after? What's your thoughts?
Well, usually from other clinicians, and actually other studies, not specifically with people with depression, but like other studies, for example, seeing effects with PTSD, they usually do the PBM treatment before any other modality, and that has shown positive results. I'm not quite, I don't know how to answer if doing before and after would be as helpful. Perhaps it could, but then there might be a higher risk of or making the client, the patient, more tired. So it really depends. But for example, there's been studies that have measured the effects on cognition and memory. For example, combining PBM with TDCS, and they do PBM before TDCS, and the combined treatment has shown increased improvements.
It's interesting. It would be interesting to do a study.
Yeah, it would be interesting to see exactly the dosage and the modalities and how to utilize PBM most effectively.
Yeah, and as you said, fatigue as well. That's something I didn't even consider. It might even support fatigue and energy.
Yes.
As you said, though, it might potentially do the opposite.
Yes. So the reader, he is he's been studying the biological markers of chronic fatigue, and they are currently conducting a study where they're combining neurofeedback with PBM, because they saw that with chronic fatigue, just single neurofeedback treatments were not adding more benefit in changing any of the symptoms associated with fatigue. So the hypothesis is that, okay, if we introduce PBM, which is adding more energy to the system, perhaps can help facilitate better improvement with neurofeedback treatment after. But the study's still ongoing, so it will be interesting to see what actually the results end up being.
I think you're going to have to present on that once the studies are out.
Hopefully this year it will be done.
I got one for your marketing department. This came out of a conversation we were having about the unrevealed TBI. People just don't acknowledge they had TBI ever in their lives, and you find out 20 hours into their training of you say, oh, I did MMA for 2 years. Oh, Jesus. Okay, so anyway, so I'm sitting here with a client who's got the helmet on her head. She goes, oh, here's a great line. If you've ever worn a helmet, you probably need this one. So give that to your marketing people. Maybe they can do something with it. I thought it was brilliant.
Yeah, we need to write that down.
Marina, do you have a question?
Yes, I'm new to this group, and I'm very grateful that I was sent the link, because I saw a Neuronic consultant to buy a helmet. I've been doing neurofeedback a long time and exploratory. The reason why I haven't done the helmet yet is because that's why I'm not sure I belong here or not. I'm doing mostly V-Light at the moment, or the X Plus, for the pure reason, the only reason is I can combine it with my exploratory training and my neurofeedback. So I do this simultaneously. And the very interesting thing that you can see when you actually put the light on while you're doing QEEG, which is, you can monitor that with Escalator, you can literally see the changes. You can see that happening real life. So maybe, John, I have the same thing. I don't have people buying. I wanted maybe the helmets that my people can buy. But I live in South Africa, so we don't have that financial capacity. So what I'm doing with the light is I'm putting it on simultaneously when I do Z-scores and Escalator. I might even add it later if I do ISF training. But mostly I do it with Escalator training, and you can literally see changes from session to session, if that answers you. So I use it because my clients won't buy it, but it makes my data training so much more effective. So hopefully I can still stay on the group, but yeah, I'll get my clients to buy a helmet, to take home. But yeah, we don't live in a country where this is doable. Yeah.
Well, having said that, Marina, and please stay in the group. I have a V-Light too, so this isn't like an exclusionary. You just have to have a Neuronic to belong here. Please forgive me if I've overstepped.
No.
But you're right about the form factor. I think there's perhaps, from a sales point of view, not to get into marketing too much, but the Neuronic is such a robust piece of equipment compared to the V-Light. The V-Light, is what it is. And it's kind of awkward, and the placement is a little more structured, and it's got its advantages and disadvantages. And you can certainly put sensors on around the V-Light, which is great. You can't with the Neuronic. But from a sales point of view, if somebody wants a home use device, I would still opt for a Neuronic over a V-Light just for form factor alone. And if you drop it on the floor, I think you're probably less likely to damage the piece of equipment than you might with a V-Light. That's just, I don't know this. Nobody's done a test, but that's my guess. The V-Light is a little more difficult to manage in that regard. You're putting on a kid's head, especially. Think about a kid. You got to deal with that. I put it on the kids here, and I got to put extra pads, and it goes on and on. But it's doable, where the V-Light is perhaps a little more awkward. But I would love to see you record, by the way. You should I think it would be informative to show, if you could, some screenshots or some short video of the changes you're seeing in real time of the application of light while you're doing a QEG. I've never seen that. I don't use Andrew's nodding. I don't use Loretta, so I can't do it myself. But I would love to see that happen. And a very, I think, evocative piece for marketing purposes, again, on the effect of V-Light on a consumer doing neurofeedback. We would all love it, whether we use the Neuronic or not.
Yeah, there's actually a very interesting study by Jason Wong, if I'm correct, where they used a laser, but they measured EEG before, throughout, and after using the laser, and the results show that there was a significant difference, like an increase in the beta range and alpha and beta bands, and that were also associated with improvements in working memory. So I think that's a really interesting study to see, the EEG patterns directly associated with PB.
And I just suggest that 10 seconds of video is going to be way better than 40 pages of charts and graphs. For the average person, they're going to go, "Oh, wow, look at that."
Yeah.
All right. Sorry, guys. It is now exactly 1 hour. I just wanted to remind everyone that we do have a masterclass available. Let me just stick that in the link if you have not yet seen it. Oh, and my chat function's not working. There we go. And it's, in case you haven't seen it, please feel free to contact us or click on that link. It contains 12 modules that we just want to continue the efforts of providing education to the industry, and we hope to help each other in this learning process. And I hope to see you next time. Our next session is May 2nd.
Yeah,
So
the master class is really good, guys. If you haven't done it, go do it. It's not, it's not a walk in the park, but it's good.
Thank you, John.
Can
Thank
you
you
join
so much.
anytime?
Thank you everyone for joining.
Thank you, everyone. Thank you, Maria.
Okay.
Can you join the masterclass at any point? though?
Anytime.
Yes.
Time, anytime.
Okay, thank you.
Bye.